Okay. Got one more comment. We'll start without it. You ready? Okay, let me have your attention. Let's begin. Welcome to the University of Tennessee Nuclear Engineering Department Colloquium Program. My name is Lee Dodds, and it's my privilege to introduce today's speaker, who is Mr. Michael Howard. He is the Chief Medical Physicist at the Watson Clinic in Lakeland, Florida. Michael is one of our own in that he graduated with a BS in Nuclear Engineering in 1992. Then he entered graduate school, working for Dr. Grower, and received his Master of Science degree in Nuclear Engineering in 1995. Then he went to work at the St. Joseph Hospital in Tampa, Florida, and he was there from 95 to 1999. And then he joined the Watson Clinic as a medical physicist and became the chief medical physicist. He's been there since 1999 to the present. He is also an adjunct professor at a local community college, namely the Hillsborough Community College in Tampa, where he teaches radiation physics. The title of his presentation today, I should introduce another person, and that is his wife, Donna. She's here too today, and so we're glad that she's here. The title of his presentation is Current Challenges in Medical Physics. So, ladies and gentlemen, please welcome Mr. Michael Howard.
Thank you very much for that introduction, Dr. Dodds. I want to thank everybody for coming today. As Dr. Dodds said, my talk is Current Challenges in Medical Physics, and I've been at the Watson Clinic for 5.5 years. We are a comprehensive cancer center. We're located about midway between Orlando and Tampa, and they have been doing radiation therapy at that center for approximately 12 years. I want to do a brief overview of my talk today. First, I want to talk a little bit about the clinical environment. A number of you have probably not too familiar with what happens on a clinical basis in a radiation therapy center. Some of you may be in a radiation-type medical physics track here at the university, and you may have a little bit of background if you've been doing some work over at the Thompson Cancer Center. Then I want to talk about some of the new innovations that are coming out. One titled Intensity Modulated Radiotherapy, also hyphened as IMRT. I want to explain what is it. It's a buzzword that's going around a lot lately. I want to talk about when it is appropriate and talk specifically about different quality assurance checks that we do regarding this type of technology. Also, I want to follow that a little bit on high-dose rate brachytherapy, which is termed HDR. It is a very common type of procedure that can be done to treat patients with various types of cancers. I want to go over some of the basic principles of HDR, along again with QA checks. And you're going to see kind of a pattern here talking about quality assurance checks. And speaking from a medical physicist's point of view, it is by far the most important aspect of our job is quality assurance checks. And I can't emphasize that enough. And when we go through these, you'll see why that they're so important. Back when I was an undergraduate here, I had Dr. Perez as my reactor theory teacher. And it was kind of funny. He told us one day that what's the difference between us and a monkey? And he said, because a monkey can be programmed to put anything in the computer, spit the information out, get it out, and hand it to somebody else. He said, your responsibility and what you're paid for is to determine when it's not right. And you are supposed to recognize when something looks funny. And that's the point of quality assurance checks, and I can't specify it enough as a medical physicist that you have to realize when something's not accurate because it has such ramifications down the road. Then I want to follow up a little bit of mammocyte, which is also a new technique that's currently being done. It is fairly widespread at this point in time, and it is partial breast irradiation. It is a new technique to treat breast cancers, but it has some new abilities that we normally couldn't do before. So it's an excellent type of treatment that's now available. All these treatments that I want to talk about today are going to be dealing with what should be currently available in the average community cancer center. And a lot of times you hear people speak about different areas or different techniques that are in research or not approved. These type of techniques are approved by the FDA. They're available in the vast majority of cancer centers across the country, and they're readily available. And it's important because so many people, most people in this room have probably known someone afflicted by cancer, either someone in their family, friends, or at some point will know someone afflicted by cancer. So I want you to understand there is many options for cancer treatment patients, and hope to explain that a little bit better as we go along. And then I want to follow up with manpower shortage, which is going to be my 2 cents on trying to recruit people into the field if it's something that you would be interested in doing. There is a very large crisis in radiation therapy today dealing with qualified physicists in the field and the lack of them. So we'll talk a little bit about that situation at the end. This is a picture of the cancer center. This is a new cancer center. It was built approximately 1.5 years ago. This cancer center is almost 40,000 square feet. It's a comprehensive cancer center in that it deals with chemotherapy as well as radiation therapy. Again, we've been there about 1.5 years. Previous to that, we were in an older building. When they put us in this new center, they gave us complete new technologies. We have the most up-to-date of everything available. It's very nice. As you notice, it's been raining. Anybody who follows the weather, Florida's had plenty of hurricanes, so this is an all-too-common scene this year, so hopefully it'll be a little drier. The clinical environment. All types of cancers can be treated with radiation. It's one thing that's important to note. Radiation has many applications. So most people think of prostate cancer, breast cancer, lung cancer, but there's more unusual cancers that can be Hodgkin's cancers, pancreatic cancers, palliative care on patients that may just have bone metastases to where they're actually just all they have is pain, and we can relieve that pain. So many types of cancers can be treated with radiation therapy. Treatment can be delivered in 2 methods. One, you can use an X-ray machine in effect, or you can use radioactive sources. X-ray machines, we term them linear accelerators. If you're not familiar with that term, all it is a fancy X-ray machine that smashes electrons into a tungsten target to create high-energy X-rays. These X-rays can be of energies up to 24 MV, so they can be very powerful. If we don't treat with that type of equipment, we'll use radioactive sources. It can be polonium-103, it can be iodine-125, it can be iridium-192. We use cobalt. There's various different types of radioactive sources that are used to treat cancers. Treatment regimens will last anywhere from 1 to 8 weeks, and that can be deceiving because most people say, well, if you're going to be getting treated for cancer for 8 weeks, that must mean that you have a worse type of cancer or the prognosis is not as good, and that's not indicative of what that means. That 8 weeks depends on the regimen. For example, prostate cancer, which is one of the most common cancers, will generally last between 6 to 8 weeks for treatment regimen, and it is very curable cancer, over 90% cure rate. We also have curative treatments that last 1 week, when we're going to talk about Mammocyte a little bit later, that actually only take 1 week, and we have various in between. So if you know people that are going through radiation therapy, it's difficult to ascertain how long they're there, have any indicative to what's their prognosis. It depends on the different types of treatments that we do use. Patients will come to the center 5 days a week. So this is an inconvenience. Patients do have to reroute their lives around this for a period of time. They come the same time every day, and in some respects it's very beneficial because everybody in the clinic gets to know the patient. You know how well they are, how they're feeling, how their symptoms are improving, and it allows a better treatment management during the whole procedure. And radiation therapy is a team approach. Can't emphasize that enough. Most patients never see the behind the scenes that goes into their treatment care. Most patients will see the physician, will see a nurse, will see the therapist actually treat them at the treatment units. They don't see the dosimetrist. They don't see the physicist. There's many people behind the scenes that work on their treatment plan. I can tell you we treat about average 60 patients a day at our center, and I'm involved at some aspect of every one of their treatment plans. But none of them could tell you who I am. But it's all done behind the scenes, so it really is a team approach. Talking a little about intensely modulated radiation therapy, better known as IMRT. What is it? In short, it's beam shaping that reduces radiation to critical structures. And I can best probably do this through an example if we talk about prostate cancer. prostate cancer, one of the more common types where IMRT is used, your prostate is located between the rectum and the bladder. Okay? The tumor is not located in the rectum or the bladder, but those organs surround the prostate. So if we're going to deliver radiation to the prostate, we're going to have to put radiation into those structures. They are what we call critical structures. In other words, they have no value in killing tumor cells. They only limit us in what we can do to treat the tumor. So by introducing IMRT, we're going to start limiting dose to those critical structures. And by limiting that dose, we are allowing dose escalation to tumors. And by allowing dose escalation, in theory, the more dose you give to tumor cell, the better chance you have at actually killing the tumor. However, most data on that, dealing with IMRT, has not come back yet. It's probably going to take another, I want to say, 5 to 10 years before enough studies have been returned to say that truly, if we're going to increase the amount of dose we deliver to a particular site, we'll actually increase the cure rate. Okay, so short term, it sounds good. People like to hear that. It works, but the long-term studies have not returned at this point. What we can say definitively is that it reduces side effects. And that is one of the biggest complaints of people that go through radiation therapy, especially for breast patients, prostate patients. You know, not only fatigue, but there's many other side effects that happen. And when patients experience side effects, they stop with treatment. If side effects become enough of a problem, doctors will put patients on breaks. Breaks can last from 2 days to 5 days. And the only thing that happens during a break is that the tumor cells begin to grow. So physicians hate to give patients breaks. If they can avoid it, they will. But if the side effects become at such a level to where the patient cannot tolerate it, the physician has to put them on a break. So in theory, IMRT will reduce those side effects. And we've seen that especially in our prostate patients that had very few complaints going through a full regimen of course compared to what we normally have. Not only does it lead to a better chance of a cure because they're not having to take breaks and have tumor regeneration, it also makes their quality of life significantly better. If somebody can go through radiation therapy and feel very good about it, have no side effects, go to work normally, be able to maintain their everyday activities, they're going to be much happier, they're going to be much more compliant, and it's going to be a better experience, and they're going to get along much better during this process. The problem comes when the side effects become too overwhelming for those to take care of. And again, a lot of patients come for radiation therapy, maintain full-time work. Some of them that are retired, they have regular golf games, they have regular volunteer work that they do that it interrupts significantly. So that is something that we really strive to work at. Next question is, how is this delivered? And you're going to need 3 key components in order to deliver IMRT. One, you're going to have a linear accelerator. That is the first critical component, and not any linear accelerator will do. IMRT is a little more advanced than what we were treating 5 years ago. So now what we do is the new linear accelerators on average cost between $1.5 to $2 million. Some are going as high as $3 million. These are what are required in order to introduce this technology into the environment. This is a typical linear accelerator here. This is a Siemens Primus. There are various manufacturers of these accelerators. However, this is a typical one. And this is the treatment couch here. This is where the patient comes in and lies down on the couch every day for treatment. And this couch is then moved up and into position where the patient will be positioned right here under the beam. The radiation is brought straight down through the head of the linear accelerator into the patient. So the patient remains fixed during treatment. The only thing that changes during treatment is the canister will rotate in either direction around that patient and deliver the radiation. Let me go back. So that's a typical linear accelerator. So once you have that installed, the next thing you need is a multi-leaf collimator, also termed as MLC. And this is one of the newer technologies. It's been out for a number of years, but continues to improve. This is an MLC. This is shot from underneath the accelerator, looking up into where the radiation comes out. So the radiation on this comes out right in the middle. So when a patient's lying under that, that opening is where the radiation will come out. anywhere you see these leaves, these metal leaves coming here, no radiation comes out. Those actually attenuate the beam. Now, this is a typical field size, not necessarily in shape, but in size, the way we used to treat patients years ago. When we used to treat prostate patients, even just a couple years ago, we would do what we call a 4-field box technique, where we would treat the anterior, the posterior, and the left and right of the patient. So it'd just be a nice box technique all the way around the patient. What IMRT has allowed us to do is no longer need 4 fields. We may pick 5 fields. We may pick 7 fields. Some people even take 9 fields and position around. And then they shrink these openings down, because you can see that this is where the radiation is coming out. This is a fairly large area. So again, we're going to be encompassing many structures where the radiation is actually coming out. So that is where we get part of the problem. But when we're doing IMRT, this MLC may look this big. It's going to deliver a very small amount of radiation to a targeted area, thus reducing the dose to various critical structures. Now, this is just one sample here. Right here is just one sample of an IMRT field. For any given patient for prostate cancer, may have 80 or 100 of these fields. Okay, so it becomes quite intensive at that point. And you can see where part of the problem lies in IMRT. Not only do we have to deal with the fact that the patient needs to be set up correctly, which is critical, we also have to deal with the fact that these fields have to be correct. And the amount of radiation delivered out of each one of these fields has to be correct. Because if one of these leads, just this leaf here, moves only to right here, we're going to have a dose error. Okay, so we have to verify that all these leaves are going to be going in the right place each time. So once you have your linear accelerator and your MLC, you need an inverse planning computer system. And this is something new that's come out within the past 5 to 7 years, widespread, and it's another unique way in which we deliver IMRT. And you have to have this to deliver this type of treatment. In the olden days, remember when I talked about when we did AP, PA, left and right lateral, what we did is the doctor came in, said, I want a 1 cm margin around the prostate, let me design my blocks, let me treat it, and now you show me what happens. How much does the bladder get, how much does the rectum get, how much does the prostate get? In other words, the computer says, this is what you can do and this is what you get. With the inverse planning system, we go the opposite. We actually go to the computer and say, okay, this is how much I want the prostate to get, this is how much I want the bladder to get, this is how much I want the rectum to get, now you tell me what you can do to achieve this. And the computer works from that backwards into developing a treatment plan that will deliver what you want. So it is unique in that it allows us to restrict dose to various structures, and while increasing dose to the actual tumor area. These systems, again, are not cheap. An average system starting is about $250,000. Okay, so they're very expensive to start up. So as you can see, if you're a new center and you want to start IMRT, you're going to invest several $1 million in this type of treatment technique. So that's why not everybody is currently doing it. Okay, now this is only from a financial standpoint. You also have a lot of labor costs that are associated with it, as well as training. The benefit from a facility standpoint is reimbursement through Medicare is much higher for IMRT treatment techniques because of the potential for better cures, the potential for less side effects. That Medicare is reimbursing much higher, so it's giving facilities an incentive at this point in order to upgrade to new technologies. Question is, when is it appropriate? In radiation therapy, we have the biggest problem where patients read on the internet, talk to friends, and before they're even diagnosed sometimes with cancer, they know what kind of treatment they want. And they walk in, they talk to the physician and say, this is what I want. The problem is they're not always a candidate for that, but once you get something in someone's mind, it's sometimes difficult to change that perception. So initially, IMRT was confined to very limited tumor sites. Prostate, breast, head and neck were the most common that was currently used. It is now branching out into much different areas, including some liver, some pancreas, some pariespinal regions. It is quickly becoming the standard care for many cancer centers. I can say that we began our IMRT program approximately 1.5 years ago. We are currently, and we have maybe 1 or 2 patients under treatment. Now about 1/3 of all our patients are treated IMRT. So it has become very effective. Treatment technique physicians are quickly latching onto it, and most cancer centers that have not implemented this technology are in the process of implementing this technology. So it's growing very quickly. The second point is limitations. The key thing is IMRT is not a silver bullet, and that is something that can't be stressed enough. It is not an end-all cure for cancer. What it does at this point in time that most physicians can say definitively, side effects are reduced, and the chance to escalate dose and get a better outcome in the end is real. But until the studies come back, all we can say at this point is you're probably going to have a much better treatment experience and be able to complete your treatment regimen with very few side effects. Also, one of the other issues with IMRT is for patients that have had lots of radiation before. We have had patients that have come back and been treated 5, 6, 7 different times. And what happens is they get so much radiation delivered to them, they're at almost their limit for critical structures. They can't take any more radiation. IMRT allows us to sculpt the dose around those critical areas and actually maybe help the patient a little bit more without delivering too much dose. Limitations heavily depend upon technology. As we said, it is only good as the technology that is delivered to it. So keep that in mind. If facilities try to spend less money to implement it in a shorter way, it tends to fail. Facilities have to have a capital commitment in order to implement this technology. Significant workload on physics staff, my favorite part. When IMRT got implemented, quickly my evenings and weekends got more soaked up. Out of everybody in the department, physicists actually have the highest workload dealing with IMRT than anyone else. Now, in some respects, I don't mind that because it's a new technology. It's always interesting to learn something new and develop through and develop the program. But if you really like to spend your evenings at home or evenings or Saturdays not at work, it can be somewhat of a problem. And intensive QA checks, and that's where the workload comes in. Again, when we normally treated a patient, we don't do these types of QA checks. We're doing these types of QA checks now because, first of all, it is required by law. All IMRT patients have to have quality assurance checks. And you can be audited by Medicare, and you have to show documentation. So it is a requirement. You can't get around it. The work actually has to be done. Each plan must be checked for dose and accuracy. And when I say each plan, if my physician comes up to me on Friday and says, I just saw 5 consults, 3 head and neck and 2 prostates, and they're all going to have IMRT next week, that means I've got to do 5 QA procedures over the next week before those patients begin. And these QA procedures are checking for 2 things. They're checking, 1, that the dose being delivered is actually the dose that was prescribed. And what I mean by that is in our treatment planning system, you can pick any point in the patient, anywhere in the patient you want, when you get your treatment plan delivered, and it will tell you how many rads of dose were delivered there. If you want to pick the middle of the prostate, and it says 150 rads were delivered at this point, I can go to the machine, measure that exact point, and verify that it's 150 rads. So we have to actually measure that the dose that was prescribed by the physician actually matches up to the dose prescribed, or the dose computed by the computer. And we're also looking for accuracy. We're looking for isodose lines. And I'm going to show you a couple pictures in a minute here, verifying that the isodose distribution that the computer generated is actually what was delivered to the patient. So we have to check 2 things. QA checks can take up to 2 hours per patient. Okay, it's very labor intensive. Now that was early on and it's somewhat improved now. But early on, you would easily spend 2 hours for every patient that you had getting ready to get started before they could begin their work. So as you can see, if you had 5 patients, you had an entire day dealing with 5 patients' work. It's probably gotten down to about an hour now per patient with some of the new technologies that have come out. And the first one I want to talk about is the Sun Nuclear Map Check. Sun Nuclear Corporation is located in Florida. They have developed a unit called Map Check. It's a diode array, and it is strictly used for IMRT QA. That's the whole development of this tool. And what it does is it uses 445 diodes over a 22 centimeter by 22 centimeter field size. And this is a picture of that unit. You can see here all these little marks are individual diodes. They're radiation hardened, they're calibrated to read properly. And what happens is this diode is placed under the beam, the radiation enters on top of this, and all these diodes collect a measurement. And this measurement reflects the radiation being delivered. This here, this is a total of 25 by 25. Okay, the majority of them are, the majority of these diodes are in this center field here area. So what it does is measures the isodose distribution and it measures the absolute dose. So it does both things that we need to do. It's going to take a measurement of the isodose distribution, which I must have, and it's going to measure absolute dose. And then that way I can truly verify that what was planned by the dosimetrist, what was signed off by the physician, what everybody believes the patient's going to receive is actually being received. And by doing that, I'm verifying that all those little leaves that we saw earlier are actually in the correct location. Because if those leaves are in the incorrect location, my quality assurance check will be wrong. And that diode array, the MapCheck diode array, can actually pick up a 1 millimeter shift in the leaves. And actually it has done that for me on a couple occasions. So again, it directly compares the patient plan to what is delivered. And I got another slide here. This is a typical one. This picture, unfortunately, is a little large, but this here is an isodose distribution that was actually delivered. Okay. So what we did is we placed this MapCheck diode array under the machine, delivered a certain amount of radiation to it, and this is what it looked like. Okay. These are all the isodose lines that was actually delivered. So it says, so when you imported that plan, this is what you delivered. This is what was planned. So this little isodose distribution over here says this is what the treatment planning computer says you should be doing. This is what you planned, this is what you delivered, and this here is the difference. So it subtracts out the difference. It measures all the points between those two plans, and it measures them on those diodes, and then gives you the difference. And then you have to have a certain criteria, which is dependent upon the facility, what actually passes. Because you're never going to get 100%. There's always going to be some variation. You have to determine what you feel is appropriate criteria for your clinic. There are no set standards in this. So this is, again, where you have to apply common sense knowledge and how you want to address the situation and what you feel is appropriate that you can expect to have accuracy. And this over here just shows a graph here of what was planned, and these little dots, again, are showing you where the measured readings are. And that just gives you another picture of your accuracy or how inaccurate your plan may be. Again, it directly compares the patient's plan to what is delivered. And again, this particular item reduces QA time significantly. Again, we're talking about cutting it in half. I can now make measurements on a patient, 2 or 3 patients in 1 hour. I can take their entire measurements. I still have to analyze it, but I can take their measurements, where it may take 1 hour before to take all the measurements you need on any one given patient. Move on to high-dose rate brachytherapy. This is a treatment technique that has been around for a number of years, but has recently become a little more common in the outpatient treatment modality. And the main reason is because patients can now be outpatients and can receive this treatment. In many years before, patients were required to go in the hospital for a couple days at a time. Now patients can actually be on an outpatient basis, come in, be treated in the clinic, and go home. So it's very, very beneficial from that standpoint. What we use is an iridium-192 source with a strength of 10 curies, which is a very hot source. Okay, it's a very hot source. And you've got to remember, when you're dealing with radioactive materials, you all well know, you can never turn it off. So you always have to be cognizant of the fact when you're dealing with it, unlike an accelerator where it's either activated or not, this material is always active, and you have to be concerned from a radiation safety standpoint of that when you're dealing with it. And actually, a little further down, I'm going to give you a story that happened. This changed the guidelines on HDR a number of years back that shows you how if you don't pay attention to what you're doing, you can get into trouble. The isotope characteristics has a gamma constant of 4.69. Its energy gamma is 0.38 MeV. That's the very good energy for radiation therapy. It is not too high for shielding purposes. It is not too low to where it can't penetrate enough distance in tissue to treat tumor volumes. And again, you see its half-life 74 days. So that, again, presents a problem. Currently, clinically, these sources are changed out every 90 days in the clinic because they get too weak. And what happens is treatment times start getting absorbently long when you go from a 10-curie source down to a 2 or 3-curie source. It becomes problematic. You can see treatment times last from 1 minute to 10 minutes per fraction. It depends on what you're treating and actually how much dose you want to deliver to that area. Now, these treatment times will steadily increase, again, as the source gets weaker. Also, you want to keep treatment times to a minimum because patients are generally uncomfortable. We treat many different types of cancers. For gynecological cancers, females have a lot of hardware placed in them for these treatments. It is extremely uncomfortable, so you want to treat these patients as quickly as possible. Before HDR caught on 10, 15 years ago, for gynecological cancers, women would have to go in the hospital for 48 hours, lay in bed, not get out of bed, not move, and for their treatment. Now they can actually come in, get treated, and be out of the clinic within 2 hours. This is good from obviously from a patient standpoint. It's also good from a health standpoint. You run into many health issues being lying down on a bed without able to move for 2 days. And there's significant problems. Actually, in one place I worked, we actually had a patient stroke during the treatment because that does create many different complications. So HDR has become very popular because patients now can do this on an outpatient basis and not be confined to a hospital. Prostate cancer is now being treated with HDR as well. A lot of you may have heard prostate cancer does permanent seeds. They place low-dose rate seeds in the prostate permanently to treat prostate cancer. Well, now what they're doing is they're actually inserting needles and delivering the dose temporarily through an HDR source, taking it back out, and the patient goes home. There are no radioactive seeds left in the patient. There's no chance of any radiation scare or anything of that at home, and there's no chance of any of the seeds migrating. So it's a great new opportunity that is slowly emerging as a common choice. It's also used for breast cancer, which we're going to talk about nanocytes shortly, and endobronchial cancers, especially when people have pulmonary lesions, when they can't breathe. It is very good at opening up blocked passageways and actually helping patients to breathe. We've had some patients come in that could barely walk, and we had one patient in particular that was actually riding a bike about 3 weeks later. This is a typical HDR unit. This is a nucleotron unit. Again, there was many manufacturers of an HDR unit, but this is just a sample one. This is actually where the source is stored, right here at the head of the unit. It retracts back in there. It's heavily shielded. These units are extremely top-heavy. You have to be careful when you're moving. They will tip very easily. This area here can be raised up and down. So if you need a different height, you can have it. This is where the catheters are attached. And again, this is a lead pig that we keep over here. This lead pig is for emergency purposes. If the source gets stuck, if the source has to be pulled out, that pig can be used. This is the front of the HDR unit. What I want to show you here is all these little channels you see going around, numbered up to 18. And the purpose of those channels is we can actually connect little tubes to every single one of these channels here and treat up to 18 different catheters placed in a patient. So if a patient is getting prostate cancer treatment, they may need 10 or 12 needles. What we do is connector tubes can connect all up there. We can leave the room, and the source will go in and out. Each tube, treat the patient, come out, so we don't have to go rehook up during treatment. So it actually works very well. This collimator here also has a lock on it. You have to turn this collimator a certain way in order to lock it. QA checks, and this is where I want to spend a little bit of time talking about quality assurance checks on HDR units. Very critical. We talk about daily QA checks. Actually, you only check an HDR from a quality assurance standpoint on days you use it. Okay, if you're not going to treat a patient that day, the HDR unit is not checked out. But if you are going to treat a patient that day, you have to verify these various interlocks and source positioning are correct. So the first thing you've got to do on a daily basis is check the source positioning, and it's got to be within 1 millimeter accuracy. And how do we do that is very simple. All we do is we take a piece of film, tape a catheter down on it, put a set of dummy seeds in it, take an x-ray, then we pull it out, connect the source up, and I tell the source to go exactly where the dummy seed should be. And when I develop that film, I better have a black mark on top of each dummy seed on the film. If that black mark is within outside 1 millimeter of each dummy seed, then it's not acceptable. So most people say, well, why is the millimeter so important? Millimeter is critical because a variation of 1 millimeter in a delivery of a patient, dose to a patient, can be up to a 5% error in dose delivery. So you've got to make sure that this source is positioned correctly when it goes out. That has to be done every day before you treat. And you have to verify that. It is absolutely critical. Door interlock must be active. The key thing in a door interlock is you need to be aware that when the door is shut, the source is out. If the door opens, the source will be pulled in. It's absolutely critical. Unlock collimator interlock, you have to verify if that collimator is not locked, it's loose, you forgot to tighten it, that the source will not go out. Blockage in the catheter, another critical aspect. If we treat somebody that's a pancreatic tumor and we have a catheter going in the patient, and I'm telling the source to go out a certain distance and there is a kink in that catheter, that source doesn't get to where it's supposed to go, it had better come back, because if it doesn't, it's going to miss the tumor. So I have to know that this is going to, when it deploys, if it can't go to the distance it wants to go, it's going to return and give me an error. So you have to check that out on a daily basis as well. You also have to check out the interrupt switch terminates treatment, because if you've got a patient on the table, you're treating them, no one's in the room, you're watching them on video monitor, and the patient has a heart attack, the patient codes, you've got to be able to hit the stop button and feel safe that that source has actually come back. If the interrupt switch doesn't work, you're going to have to enter the room with a high radiation source out and go through another emergency procedure in order to return. The one thing I did not put on here, which is critical in the story I want to share with you, is about a survey meter. You must have a survey meter when you're dealing with HDR. And this happened a number of years ago at a facility that will not be named, not anywhere I worked or in Tennessee. They treated an elderly woman, gynecological cancer. The source went out. Physicist was not on site. The source went out. They have an in-room radiation monitor that blinks when it detects radiation, but it had been on the blink. It had been going on and off. 2 therapists treated the patient. Treatment terminated. They walked in the room. They unhooked the patient, and one of the therapists noted that the light was still blinking. She's like, don't worry about it. It's been off and on. It's not working. So they removed the patient, sent the patient back to the nursing home. Everybody thought it was fine. That was on a Monday. On Friday, the physicist gets a call, and he gets a call from the local dump saying, we have your source. And he says, I have no idea what you're talking about. He's like, no, we got your radioactive source here. It's set off for radiation monitors. It was in a bag, blah, blah, blah. So the physicist immediately panics, runs, grabs his survey meter, surveys HDR unit. There's no reading. So immediately he realized the source was left in the patient. So he goes to the physician, finds out the status of that patient. Physician says, you know, it's ironic, that patient died. That patient died on Wednesday. And it turns out that patient received well over 1 million rads locally deposited dose, plus all the nursing home personnel that dealt with that patient around a 10-curie source had significant exposures. Okay, so that led to significant rule changes in accordance with the NRC and local state governments agreeing. And first of all, you have to have a physicist or a surrogate on site at all times. You have to survey that patient. If they would have just bothered surveying that patient, they would have figured this out, and it wouldn't have happened. So that's, again, an example of quality assurance. You've got to take the little steps, and you can avoid massive problems that incurred there. Mammocyte, this is the new HDR technique that's come out. It's partial breast irradiation. And what it does is, before, when women were diagnosed with breast cancer, they had to have their entire breast treated with radiation. There was no other alternative. They had to come in for a period of approximately 6 weeks for treatment. With the advent of Mammocyte, now it's partial breast irradiation. So only a limited area of the breast will actually be treated. You're going to deliver 3,400 rads to the planned tumor volume, and all the PTV means is just the area where it's most likely any residual tumor is going to be remaining. The dose is delivered in 10 fractions twice a day. So now this patient is going to be treated in 5 days. What would involve the patient coming over a period of 6 weeks has been reduced to 1 week, okay, which is very beneficial, very beneficial. It uses a single dwell position for the iridium. And let me show you a mammocyte balloon. Kind of goes off the end here, and I'll show you inflated. But what happens here is this is where a saline solution is injected. The source comes in here. There's a central lumen running along here, and then this is the balloon. And there's the center notch of the balloon. And that source will drive out, sit right in the middle of the balloon, and deliver the radiation in return. So you can see how the balloon looks flat. This is a balloon that is properly inflated with saline. Fairly large, okay, and fairly uncomfortable. Most people adjust to the pressure within a couple of days, okay, so it doesn't take very long to adjust to the pressure. This is a CT scan cut with a balloon in place. This is the balloon deposited in the cavity where the lumpectomy occurred. And it is inflated with a saline solution. And this is exactly where the source will come right to the middle of this and deliver its radiation. And what we're doing is we're delivering it to approximately 1 centimeter beyond that balloon is how we're prescribing our dose. Because it is determined in most cases 90% of any residual tumor will be left in the first 1 centimeter. Olden days, remember, we talked about the entire breast had to be irradiated. So just 5 years ago, if you wanted, even if you had a lumpectomy, clear margins, you had to have your entire breast irradiated in order to receive radiation therapy. Not anymore. This is what we call partial breast irradiation. One other benefit to this that is critical. If a woman comes in and gets treated with this tumor cavity right here, and say 15 years later comes back with another breast cancer in that same breast, she can now be treated again. If she gets another tumor here, they can insert another balloon and treat her because that part of the breast has not been irradiated. So it gives you an option later on with a chance of recurrence, which does happen. The breast has not already received its maximum dose from the original radiation therapy. So it gives them another treatment option depending on what may occur. It also reduces side effects. You have a lot of skin breakdown on breast patients, okay? With the mammocyte, there is no skin breakdown, okay? So that does not occur at all. The protocol is extremely limited. It is not for everyone. Again, we have women that come in that want mammocyte. They're not a candidate. That's becoming quite common. Currently, we've performed approximately 25 to 30 of these procedures this year so far, which is a pretty heavy load for most cancer centers. It is also an excellent option for rural communities, okay, because if you're living too far away, you're not going to come and get treatment. We have that some options are the patients live 2 hours away, and they cannot drive back and forth 4 hours for 6 weeks. So they're like, if I can't have mammocyte, I'm just going to go ahead and not get any treatment at all. I don't have any other choice because I can't do it. So it is an excellent option that's been developed for rural communities to where patients can now just come for 1 week and get their full treatment. And to close up here with manpower shortage. There is a severe shortage of qualified medical physicists. It is growing worse, honestly, by the year. It's specific board certified, okay? But it has become such an increasing problem, one, because there's very few accredited schools for medical physicists. Okay, there's just not that many out there. And the ones that are out there are graduating 3-4 people a year. That is not going to keep up with a large retirement age of physicists. If you ever go to an AAPM meeting, you're going to see the average age is probably mid to late 50s, some in their 60s, and they're retiring. And there's not enough young people getting into the field to take up that slack. It takes a long time to make a physicist. In accordance with current regulations by the American Board of Radiology and the American College of Medical Physics, you have to have a minimum of a master's degree to be considered a qualified physicist. But not only that, you have to obtain board certification. Board certification is a long and tedious process. It involves 2 written exams of approximately 8 hours total, and then requires an oral defense. Mine lasted for 2 hours in front of 4 physicists, in which you have to answer lots of questions, and it's not a pretty scene. But it takes a long time to do. Okay, so it discourages a lot of people from getting into the field. It's not a quick and easy field to get into. If you got your master's degree or you're in the process, you've considerably dropped the amount of time you need in order to become a physicist. The next step is to get in the clinical environment, begin your work process, and then sit for your boards. So once you begin your clinical process, you can generally sit for your boards fully in about 3 to 4 years. Okay? It is an extremely rewarding career with high pay. That is one of the draws to this field, is extremely well-paying field. I can tell you the salaries have gone out the roof, okay, across the nation, because there are not enough physicists. And one of the problems with this has been hiring people that aren't qualified. And the problem is no one knows if you're qualified or not, because no one in a facility, neither a physician nor administrator, knows what we're doing. So you can present yourself any way, shape, or form, seen it done many times, and you have no clue what you're doing, and no one can determine. And I can give you an example at my center. I'm the only one that knows that that machine's calibrated properly. The doctor prescribes a dose based on that machine being calibrated a certain way. Patients believe they're being treated properly because they think the machine's calibrated. Therapists are treating patients because they think the machine's calibrated. I'm the only one that knows. Okay, so it's an extremely high burden for one person to carry, and that's one of the things you have to learn in this field. You have a lot of responsibility. This isn't something that you can just push to another person. There's a lot of repercussions, because if I don't calibrate that machine correctly, then every patient's going to be mistreated. So that's something you have to feel comfortable with, ask questions, learn, go to meetings, go to seminars, and learn how this information is done. And also, again, like we talked earlier, when something doesn't look right, if I calibrate a machine and it's 3% off, I immediately start questioning everything I've done, because I know my machines are never 3% off. So you have to go through a certain process in order to do this. It's extremely rewarding. You get to see patients get better. Okay, most of the time you can't say that in most jobs you go to. Most of the time you do your work, you never see the end result on the other side. We see patients that come in. We had a brain metastasis patient that came in one time on a stretcher, didn't even know his name. At the end of the week, he was walking, he was talking, he was coming in and out. So you get to see a lot of benefits in this field that you don't normally get to see. And it continues to change with new technologies. They're coming out every year. Something always new is happening. There's a lot of new things to get involved with. So if you like new technologies, you're going to enjoy the field. And in closing, again, medical physics is a challenging field, albeit very rewarding. If you like working with radiation generating type machines, radioactive sources, it's a great field to be in. Quality assurance is an essential aspect. Opportunities exist in research as well as clinical environments. If you don't like the clinical environment, don't like being in hospitals, don't like working in clinics, you can work in research. There's many, many physicists that work nothing but research, work in labs, work in development with various manufacturers of equipment that don't ever have to set foot in a facility. So you have many options once you get into the field. And nuclear engineering is an excellent primer for medical physics. It worked wonders for me. You can put a lot of what you learn here in the program into use. And I think it's a valuable way to get started into the field, because there are just not enough accredited physics programs to get your way into the field. There has to be another mechanism, and nuclear engineering, I think, is one of the better ones. Okay.
All right. We have time for questions and comments for Michael. So we have questions, comments. I have a question.
Okay.
It's extremely rewarding. Students usually think in terms of what are the starting salaries, and of course that depends on whether or not you've been board certified or whether you're just beginning some clinical experience.
If you're just coming out of school, starting out as a junior physicist, they're starting generally between $90,000 and $100,000. I've seen some a little higher.
That would be the person that just graduated with an MS degree who's not yet board certified.
Correct. 90
to 100,000. That get anybody's attention? Now, after you get board certified, after 3 or 4 years, what would be the average salary of a board certified?
If you're a chief physicist at a facility, probably between 150 and 200 per year.
Where do I sign up? Any other questions? Or?
Same. Research. Recertification, I'm sorry. That is changing actually as we speak. Currently, you have to, the American Board of Radiology has changed those requirements, and they used to have an indefinite recertification process where you never had to go again. Now they're actually doing maintenance of certification, so you're going to have to do every 10 years. You're going to have to do several projects, take exams online, and also fill out some paperwork. So it's going to go to every 10 years.
Martin?
Do you carry malpractice insurance?
If you are a consulting physicist, it's essential you carry malpractice. My facility carries my malpractice for me. But if you are individual, there's a lot of physicists that contract to different facilities. And if you are a freelance physicist out on your own, you have to carry malpractice because you will be drug in on any issue that does come up. So if your facility doesn't carry, but all major hospitals, clinics, all carry it on their own staff. Yes. Physicists are a funny bunch. They don't like talking to other physicists a lot of the time, and I don't know if it's they're afraid that they're doing it wrong, but I think more peer review is starting to occur, and more people are communicating to one another. But I can strictly speak from going to meetings. When I ask people what they do in a certain situation, I get a lot of gray talk, and I think people are really afraid because it is a very open field. Everybody does things differently, and no one is, there's 50 ways to calibrate a machine. There's no one to say definitively if you did it correct or not. There's certain ways you can measure that. So people don't like talking about it, but I think the more peer review you get, the better it is. Absolutely. That's a big problem in the field.
Does the machine manufacturers have a lot of responsibility to specify how to calibrate their machine?
No. They have no specification. The American Association of Physicists in Medicine, called the ABM, has issued Task Group 51, which is their recommendation on how to calibrate a machine in the United States, and most people adopt it worldwide. The problem is there's an independent monitoring group called MD Anderson that will check those. You can send diodes and measure it. Only a certain percentage of institutions even submit the diodes. We submit them our facility, and what they do is I'll deliver amount of radiation. They'll tell me if I'm really got the machine calibrated correctly. I couldn't imagine not doing it. A lot of facilities don't do it. So there are a couple different ways to calibrate a machine.
Other questions or comments? Let me add some information. Oh, there's a question back here.
I can say, for example, University of Florida is accredited, and from my experience, I actually did an interview with a physicist that was just graduating University of Florida. And problem with accredited schools, quite honestly, are they had no clue about clinical environment. They're not even the basics clinical environment. I could take somebody off the street and they knew as much about the clinic as that person did. To me, I'm seeing that they're teaching more of the theory, which is important. But if you're going to come out of accredited school, most people think you can walk into the clinical environment and function. And what I'm seeing is a lot of them cannot. So last time I checked, there may have been about 10 or 12 accredited schools. Some of them are starting up a little bit more, but there's a number of non-accredited, which the program here is non-accredited, but it graduates physicists along the same lines. You have clinical rotations over Thompson Cancer Center, and it serves the same purpose. But I think these schools need to really try to gear toward more clinical environments, so when they come out that they can actually contribute immediately in that scenario.
I should point out that our program has produced several, I'd say at least 6 and maybe 12 MS graduates like Michael that have gone on to become board certified in medical physics. So Michael in that nuclear engineering is excellent preparation for this field. We have a lot of people out there working as medical physicists right now. And before we adjourn, there's one other little piece of information I want to share with you. He talked about the nice salaries that these people make. Michael and his wife have endowed a scholarship, an undergraduate student, nuclear engineering student here at UT. And this is going to go on for several years. And so he's clearly the type of graduate we'd like to produce, where they go out, make lots of money, and send money to home institution. So, yeah. So, are there any other questions or comments? I do see, again, we seem to always have a few new faces each week attend our colloquium. And so those people may not know that we have a reception immediately following this presentation, and everyone is invited. Okay, it's downstairs on the second floor. But before we adjourn, let's express our appreciation again to Michael for his presentation today. Okay, thank you.
What are you going to express? I have to do accreditation. The only time you photograph, you tell if he's doing better than the person. Michael, thank you.